Good morning, everyone. I'm Tony Monaco, president of Tufts University. Welcome to this global health seminar regarding the COVID-19 crisis in India and the South Asian region. I understand that our audience today joins us not only from across Tufts, but from different parts of the country and from around the world. Thank you all for joining us for what should be an enlightening discussion on this important topic. But let me start by reminding us all that the reason we are gathered here today is because of an immense crisis that is ongoing in India and South Asia. It is difficult to describe the loss and the pain that has resulted in this region from the COVID-19 pandemic and is continuing as we meet. The Tufts community has deep ties to this region, and sadly, some of our community members have been directly affected by this crisis and have experienced personal losses. Furthermore, many individuals at Tufts have family, friends, and colleagues in the region and are worried about their well-being. Many students are also unable to travel home as the academic year concludes because of travel restrictions. I am committed to making sure that Tufts will always stand by in support of the Indian and South Asian community at our university and will support their needs in every way we can. But as a research university, our commitment must go much further. And we are convening this seminar as an example of coming together within the academy to learn more about the crisis and explore ways where we can be supportive of efforts through scholarship and research to turn the tide in India. I now have the privilege of introducing and welcoming today's speakers and panelists. We are joined today by Gugan Cherry Kang, MD, PhD, FRS. Dr. Kang is a professor of microbiology at the Wellcome Trust Research Labs, Division of Gastrointestinal Sciences at Christian Medical College, Vellore, India. Also joining us is Dr. Bhramar Mukherjee. Dr. Mukherjee is the John D. Kalbfleisch Collegiate Professor of Biostatistics, Epidemiology, and Global Public Health, and Chair of Biostatistics at the University of Michigan School of Public Health. Thank you to Dr. Kang and Dr. Mukherjee for making the time to join us and sharing your expertise on this topic. I should recognize the special relationship that the Tufts University School of Medicine has with the Dr. Kang's institution, the Christian Medical College, or CMC, in Vellore, India. Over the past 3 decades, our two institutions have collaborated closely, and I am grateful for the partnership. I had the good fortune to expand on this partnership not too long ago during a very memorable trip and signing ceremony in India. In addition to the School of Medicine, other schools at Tufts, such as the School of Engineering and the Friedman School of Nutrition Science, are beneficiaries of research collaborations with CMC Vellore. So again, thank you to everyone for joining today. It's now my pleasure to welcome Tufts University Provost and Senior Vice President Nadine Aubrey to share a few words of welcome. Nadine?
Thank you very much, Tony. Good morning, everybody. I too would like to welcome all of you to today's Global Health webinar on the important topic of the devastating COVID crisis in India and South Asia. Thank you all very much for joining us today. First, let me thank our speakers and panelists who are with us today, particularly Dr. Cherry Kang, Professor of Microbiology at the Christian Medical College, CMC, in Vellore, India, and Dr. Bhramar Mukherjee, John Kalbfleisch Collegiate Professor and Chair of Biostatistics at the University of Michigan School of Public Health. At this occasion, I'm delighted to acknowledge the highly productive collaboration between Tufts University and Christian Medical College in Vellore, India, particularly with Dr. Cherry Kang from CMC, who also holds an adjunct professor academic appointment at Tufts School of Medicine. Dr. Kang, thank you so much for collaborating with our faculty and mentoring our students over the years. Collaborations between Tufts and CMC have been on a number of topics related to the treatment of a broad range of diseases, as well as bioethics, and have been sponsored by NIH, the Gates Foundation, and the US-India Educational Foundation. Such collaborations, I'm proud to report, involve faculty and researchers from CMC, Tufts School of Medicine, the Friedman School, the School of Engineering, and Tufts Medical Center. Let me now express my deepest sympathy to individuals, families, and communities in India during the second wave of the COVID-19 pandemic. I know that many members of the Tufts community, including faculty, students, and staff, have family ties there, and many are suffering personal losses of family members and friends. It is in these difficult times that the Tufts community is seen at its best, supporting and helping those in pain during this formidable crisis. Finally, I would like to thank all the members of the planning committee for organizing this seminar and panel discussion, particularly Dr. Honoring Ward, Dr. Ram Subaraman, and Dr. Joy Saki, and our co-sponsoring schools and offices, including Tufts School of Medicine, Tufts Medical Center, Tisch College of Civic Life, the Office of the Vice Provost for Research, and the Office of the Provost. It is now my pleasure to call on Dr. Peter Bates, Interim Dean of Tufts University School of Medicine, as the next speaker. Peter.
Thank you, Nadine. And I want to extend my welcome also to everyone to today's seminar. I want to thank Dr. Joyce Saki and colleagues for putting together this seminar at a very important time on a very important topic. As the invitation to the seminar said, India's tragedy is our tragedy, and I look forward to learning with all of you today. Now, without any further comment, I want to introduce Dr. Saki, who is the Dean for Multicultural Affairs and Global Health at the Medical School, and also Associate Provost and Chief Diversity Officer for our Health Sciences schools. Dr. Saki.
Thank you so much, Peter. I'd like to add my welcome to our global audience to this webinar, and a warm welcome to the speakers who've joined us today, Dr. Cherry Kang and Dr. Brahma Mukherjee. I also want to acknowledge that I had the fortune of visiting Vellore, India, several years ago with our former Dean, Dean Harris Berman, and have had occasion to not only spend time with Dr. Kang in India, but also host her when she's been visiting here at Tufts. I want to make a special thanks for the mentorship that you've provided to our students and trainees over the years, and of course, the fact that you also have many collaborations with our faculty around research, as has already been mentioned. Everyone has mentioned already the long-standing collaboration between Tufts and Christian Medical College. But I thought I would take occasion to give you a sense of the extent of the influence or the impact that this has had on our students and trainees. So up until last year, when we had to suspend our global health programs, we were averaging about 15 to 20 Tufts medical and public health students per year going to CMC Vellore for electives, observerships, or to do research projects. Although travel to India for Tufts students was suspended last year due to the pandemic, 2 students were still able to complete virtual research projects thanks to the incredible collaboration with our colleagues at CMC. And now I'd like to give a brief overview of the logistics for this morning. Please use the QA function to post your questions, and we will make sure that once our speakers have given their introductory presentations, we will pose your questions to them during the panel discussion portion of it. Now, let me invite to join me to introduce our speakers, 2 of my colleagues here at Tufts and members of our planning committee, Drs. Honoring Ward and Ram Subaraman. Dr. Ward is a professor of medicine at the medical school and a member of the Division of Geographic Medicine and Infectious Diseases at Tufts Medical Center. A graduate of CMC Vellore herself, Dr. Ward is our faculty lead for the Tufts Global Health Program in India and has mentored scores of students and trainees over the years. Her research area of focus is infectious diarrhea diseases, particularly cryptosporidiosis in children in Southeast Asia. Dr. Subaraman is an infectious disease physician and epidemiologist and assistant professor at the medical school. His area of focus is implementation science research on strategies to improve delivery of tuberculosis care and identifying the social determinants of health that can get in the way of that care, particularly in urban settings. His scholarly pursuits have taken him all the way to India, where he has done public health research in urban slums and has also pursued advocacy work. Following the introductions of the speakers, you will then hear from our speakers. So at this point, I'm going to call on Dr. Subaraman to do our first introduction. Ram?
Thank you so much, Dean Saki, for the introductions and also for your efforts in pulling this together. It's my pleasure today to introduce Dr. Brahma Mukherjee. Professor Brahma Mukherjee is the John D. Kalbfleisch Collegiate Professor in the Departments of Biostatistics, Epidemiology, and Global Public Health at the University of Michigan School of Public Health, where she is also chair of the Biostatistics Department. She has co-authored more than 200 publications, and her research as a statistician, data scientist, and public health expert spans the fields of cancer, cardiovascular diseases, reproductive health, exposure science, and environmental epidemiology. While her research is prolific, and I certainly can't cover all her accomplishments here, I would like to highlight her recent work that is directly relevant to our topic today. Since early 2020, Professor Mukherjee has been involved in modeling the trajectory of the pandemic in India in collaboration with the COVID-19 Study Group, which has a really nice website if you Google it, to provide real-time insights into policymakers. Earlier this year, Professor Mukherjee was one of the earliest voices raising alarms about a possible second wave of COVID-19 in India, fears that sadly turned out to be correct. During the second wave, she has also been a prominent public voice arguing for implementation of evidence-based public health interventions that could curb transmission and save lives. We are privileged to have her insights today, and welcome to Tufts, Dr. Mukherjee. I will now hand off to Honorine Ward to introduce our second speaker.
Thank you, Ram. I'm delighted to add my introduction and welcome to Cherry Khan, as she is known. Cherry is no stranger to Tufts, as President Monaco and Provost Aubrey and Joy Saki have mentioned. She has been to Tufts many times and has been a long-time co-PI of mine and collaborator on NIH-funded research and training programs at Tufts Medical Center and Tufts School of Medicine. Her work has focused on development and use of vaccines for enteric infections, conducting large studies to define burden, test vaccines, and measure their impact. Cherry has published over 375 scientific papers and received numerous awards and honors for her work, too many to list here. Most notably, she was the first woman in India to be elected as a Fellow of the Royal Society and of the American Academy of Microbiology. During the pandemic, she has worked on serosurveys for COVID-19 in India and has served on national and international advisory panels on SARS-CoV-2 and COVID-19, particularly on vaccines, which she's going to talk about today. She is vice chair of the board of the Coalition for Epidemic Preparedness Innovations, or CEPI, and a steering committee member of the COVID-19 Clinical Research Coalition, both international organizations. She was recently named to the Indian Supreme Court appointed COVID-19 Task Force for Equitable Distribution of Oxygen to States. She has been a voice of reason in the national and international media, focusing on the science of COVID-19. Cherry, welcome back. It's a privilege to have you with us today. I turn it back to Joyce, or I'll invite Dr. Brahma Mukherjee to give her presentation. Thank you.
Thank you so much. Thank you, colleagues at Tufts and worldwide for organizing this important symposium and being a part of it. As it was mentioned in my introduction, that infectious disease was not a part of my research portfolio until last year when this pandemic started. And I'm really, really fortunate to share this virtual podium with an outstanding scientist, Dr. Kang, that I sincerely admire as a pioneer and as a trailblazer. So I would like to tell you a story how I got into modeling this pandemic for the last 400 days every day. So it was the first day of the stay-at-home orders at University of Michigan, when many of us, primarily from the Indian diaspora, but also many others, joined hands and forces and minds together to build a tracker for the pandemic trajectory in India. And initially, we did not think that this work had such a longevity and impact. And many of our students, just it was mentioned, were very anxious about what was coming, and they were separated from their families. We wanted to repurpose their anxiety into a meaningful project. And as public health data scientists, what else could we do except to model? So we have really tried to compute our way of the pandemic, and anything that I'm presenting is really the work of an army of data warriors. I always say I'm a data dreamer, but I'm not the only one. So together we built this tracker, which has been running for the last 400 days. The website is covid19.org. And all our papers, all software, anything that we have done is publicly available in a true commitment to reproducible and rigorous science. I always say that the data from India is imperfect and there are challenges, but we have to put our best modeling foot forward. So if you logged into this app, you will see many snapshots of the pandemic in India, including multiple public health metrics. So as you see in this snapshot table, it gives a comparison of today with yesterday, a week ago, and a month ago. And you can see the case counts and how deaths have not slowed down as much, but cases have slowed down. So you can get a sense of the relative change in the trajectory. So 3 points I want to make today, and I have been given 10 minutes, so each of them will have 3 minutes each. I want to talk about wave 1 and wave 2 briefly, where India stands. Then I want to talk about an issue that I have spoken and written a lot about on underreporting and where is the real situation with respect to the number of cases and deaths according to models. And then I want to talk about, was this virus inferno unstoppable? Could we have acted early and prevented deaths? So I just want to give you a snapshot first of wave 1 and wave 2. And I want to compare with the United States because that's very immediate to our experience. And you can see that this is a latest, and again, I can show you the latest data from yesterday because of the tracker. I don't even have to ask my graduate students before every meeting. So you can see that the virus, the height of the daily number of new cases and deaths in India skyrocketed in the second wave. And usually, as we see in the United States as well, the second waves are usually much vicious and ferocious and comes with a velocity. But India's one was actually really at the high point. You know, India was reporting more than 400,000 cases, and the deaths peaked at about 4,500 reported deaths. And all seroprevalence surveys and investigative reports suggest the actual reality is much more dire. And talking about families, the second wave have left really very few families untouched. So you can see the magnitude and impact of this wave. But I'm a data scientist. As we have to define wave 1 and wave 2, you might think this is very naive, but I am going to discretize the time interval because in order to calculate numbers, I need to define wave 1 and wave 2. So I'll give you a history of the pandemic that the national lockdown in India last year was very early, fairly early on March 25th, 2020, it started, so you can see the period. And then India truly probably flattened the curve, and wave 1 ended with the height of the peak at about 98,000 cases on September 16. And then the curve went down, and all scientists were trying to explain this miraculous decline when on February 14th, after a 5-month decline, the R, or the effective reproduction number, started crossing unity. So the signs of the uptick was really on Valentine's Day. And as you can see that since then, it really, in the beginning part of the exponential growth is really slow, but then it exploded into this virus inferno. So I'm going to take this period as wave 1 and the other period starting from February 14th as definition of wave 2 as I present these numbers. And so where does India stand now? You can see that as of May 25, reporting 27.4 million total cases, 315,000 deaths. The good news, in 2 weeks ago, I was not so happy, but now I'm more relieved to see the test positivity rate curve turning down and coming down to 12%. At one point of time, it was 25%. And then the R also going below unity, and you can see the curve has turned the corner. But it would be really inappropriate and unwise of me to say that India's national peak is reflective of all the states, because India's national peak is really driven by 4 or 5 very large states and big metros. Rural India and also many other states are actually experiencing the crisis as we talk right now. Coming to vaccination, and Dr. Kang is going to give you a complete picture of the vaccine story, but 3.5% of Indian population is fully vaccinated, and about 13% with at least 1 dose. The case fatality rate in India has always been low, and a composite case fatality rate is now around 1.1%. So this is the vaccination distribution graph, daily vaccine numbers. India has delivered more than 200 million vaccine doses, but it's a very large country, and that's why the percentage of population vaccinated looks small. And so for the last few days, there has been variation, but you can see the number of daily doses delivered of the vaccine is around 2.5 million. And all calculations projected that you have to get to 10 million daily doses in order to vaccinate the adult population in about 6 months, 6 to 8 months. So, and I'm just going to show you some numbers, and I always tell my stories through numbers because, but I can never forget that behind each of these numbers is a person and is a family. And my own father is battling COVID right now. He's recovering at home, had to be hospitalized. So when my father became a data point in this time series, I have a different perspective of this disease. So, and this table actually just compares that to show you that the second wave was much more stronger and came much more enormous than the first wave. So every day we track every state. And as I was mentioning, we showed India's national peak, but many states are still not out of the woods. And I have marked some of them. Every day we update this metric, and this metric has case fatality rate, test positive rate, daily new cases, vaccine doses, and it all gets automated, and we track the pandemic at a much more granular level than just looking at the national numbers, which is often misleading for India. And so point 2 I want to make is underreporting. What is the true state of the pandemic in India? A couple of days ago, New York Times came out with an article and also an estimate of the total number of deaths that could have happened based on their conversation with several scientists, reports from crematoria, investigative reports. So how can models help to get at these numbers? And I have to say that it is nearly impossible for any country to capture all COVID-related deaths and infections. And part of that is because many infections are silent or covert infections. But also in India, due to bottleneck in testing, I think many of the symptomatic cases were missed, and also rural area stigma associated with testing. And if you don't get tested, you don't get classified as COVID-related hospitalization or fatality. And similarly, cause of death misclassification is very common. But why are we so concerned about India's reporting then when the whole world is facing this problem? So how can models help? We built this model, which actually has compartments for unreported cases. This is an extension of the classic ACIR model, which also from the natural parameters that we know about the properties of this virus from this 14 months of experience can capture the latent compartments of unreported deaths and unreported cases. And I'm just going to show you that in wave 1, we consistently estimated that for cases, the underreporting factor was from 10 to 20, and for deaths 2 to 5 in India. And that will lead us to an infection fatality rate, given if we believe the observed data and if we actually infer about what is being missed, infection fatality rate of 0.1 to 0.5%. And so this may seem like a small number, but if a large number of people in a large country gets infected, that could lead to a massive number of deaths. So what these models actually do is to give you this like a sense pictorially that a small fraction, you only see a tip of the epidemiologic iceberg. This whole blue part are things that we miss. And this is something that the models can produce. And you might say that, these models make a lot of assumption. I'm just going to show you some fresh data that we just submitted a paper to medRxiv about estimation of this underreporting factor and the total number of infections combining wave 1 and wave 2. And what we see in the models using the same parameters is that underreporting has been much more acute in wave 2. So in wave 1, this was 11, and now it has gone to 26 for the period of February to May. And according to our calculation right now, 36% of the Indian population has the infection, with a staggering number of 492 million infections and 1.2 million deaths. That will give you an infection fatality rate around 0.24%. But again, I just want to show you, and I have plotted these numbers on the log scale because it's so huge that you cannot fit it in the same scale, but you can get to these underreporting factors. So what we were seeing on the ground may be only a bit. And there is substantial variation across the waves in terms of fatality rate and across the states. Different Indian states really behave in a different way because of healthcare system and policy differences as well. So how can we verify these numbers? Is there any sense to it that 36% of Indian population is infected? I'm making this tall order claim using models which use a lot of assumptions and wrinkled with assumption. So for wave 1, we could validate it because Dr. Kang is part of many national seroprevalence survey, which said 21.4% of the adult Indian population had a past antibody, which is a sign of past infection. That will naturally point to about 180 million infections in India by January. And so now we have seen this wave. So I do not think that this is a very unreasonable estimate of having around 500 million infections to be estimated. So can we verify death? If the data was available for historic trend data on mortality, then we could do a similar type of excess death calculation, which US has also done, and found that the total impact of COVID-related deaths is much higher than what it's reported. 22% excess mortality, according to a paper in JAMA, 72% attributed to COVID. We'd love to do this kind of calculation if the data from India will become available rather than relying on anecdotal evidences from obituaries. So could we have the third point, the final point, could we have done something about it? Was this unstoppable that we just had to surrender to destiny? We know enough about this disease. So I'm showing you examples of Delhi and Maharashtra, where there were lockdowns, and you can see that from the peak to the number of cases we have now, remarkable coming down of the curve as well. Even with data imperfection, we know public health interventions work. Simple things, wearing masks, avoiding large gatherings, and maintaining social distancing. And also if you get to a point where lockdown is the only way out, and they work. So we wanted to play sort of a policymaker in a computer and say that if this lockdown that happened in Maharashtra, that happened in Delhi, or the national lockdown that will happen last year, if that was something like that was implemented in India earlier on in March or in April, what would have happened? Could we have turned the curve around? How many cases would we have prevented? How many deaths would we have prevented? And again, I speak about this with caution because there is a lot of uncertainty. To simplify the presentation, I'm just showing you that the peak that we saw at 400,000, if we acted in March, if we acted in April, if we acted in mid-April, we could have saved many infections. And these models can actually quantify the total number of deaths and the total number of infections that could have been prevented. And our calculations say that if we actually started with an intervention on March 15th, even by April 15th or April 30th, we would have averted about 3 to 8 million infections and about 15,000 to 52,000 lives. And with that, I want to conclude. I tried to make 3 points about data, through data, and all the information is public. And I want to say that the country has gone through so much pain, but I do believe that we have to keep walking, keep working, keep fighting. This is a poem by Rilke, which says that life is like that, history is like that. Let everything happen to you, the beauty and the terror. Just keep going. No feeling is final. I hope beauty and truth is waiting India around the corner. And I hand the podium over to Dr. Khan.
Thank you very much, Rama. It's always such a pleasure to listen to you, and I always learn something new. I think the last time we spoke, it was not in such a happy circumstance. So now I'm going to talk to you about what has been done as interventions in India. So this is really covering vaccines and vaccination in India. And I'm going to use a few graphs to tell you where we are and specifically where I am. Now, you saw from the presentation that Dr. Mukherjee made that our second peak is trending down very sharply. We don't have time to cover the fact that in some places testing kept pace with positivity and other places it did not. So while we have a composite picture, we think that there is variation in the data that is available from different parts of the country. In this blue graph here, I'm showing you data from the state of Tamil Nadu. And you can see that we've been through a bad couple of weeks. We went into lockdown about 2.5 weeks ago. And this small downward trend that we have just about begun to see is a result of that lockdown. The hospital currently has almost 1,000 inpatients. And every day we are trying to manage patients in the community. We were very fortunate to receive donations of oxygen concentrators, and we've been able to distribute them around town. And most of my research team is working full-time manning phones and delivering things, whether it's medicines or oximeters or concentrators or food, to the families that are around us. Now, where are we in terms of vaccination? Shown here in the graph is the percentage of the Indian population that has been covered with 1 dose of vaccine. It's about 12% now. And with 2 doses, we are just under 4% of the country being covered with both doses of vaccine. We actually didn't start very late. We started on the 16th of January, and until the end of January, we were vaccinating healthcare workers. Then we switched to including essential workers, and this included the army, police, and other people who were considered essential workers at the state level. On March 1st, we included all people over 60 years of age, and then on April 1st, we included everybody over the age of 45. On May 1st, we opened up vaccination to 18 to 44-year-olds as well, essentially indicating that all adults in India could potentially receive vaccines, but we set up to do it in a somewhat complicated way. The central government said that they would provide vaccines for all over 45-year-olds as long as they were willing to receive it at a government facility. And then the state governments were going to be having to pay for vaccines to the two vaccine manufacturers that we have at a price that was at least double what the central government was paying. And states would need to compete with the private sector to be able to buy vaccines. So that was complicated. It took some time to sort out and isn't really sorted yet. In terms of the share of the population shown here in the map, you can see that India is under 5%, and we really have a very long way to go compared to many other parts of the world, North America, South America, Europe, or parts of Northern Asia as well. Now, this is a bit strange because if you think about India's place in the world of vaccines, before COVID, about 4 billion doses of vaccines were used worldwide, and almost 2 billion of those doses were made in India. India was producing about 60% of the vaccines that were used for routine childhood immunizations around the world. So 60% of the vaccines procured by the Gavi Alliance, as well as vaccinating its own birth cohort, which is 27 million children. So, if you have 3 vaccines that need to be given, that's 90 million for a birth cohort of Indian children alone. So India is very good at making high volume but low value products. So even though we made a lot of doses of vaccine, in terms of global valuation, it was a relatively small amount. India was expected to be a key contributor to the COVAX facility, which is intended to distribute vaccines for 20% of the population of 92 countries eligible to receive vaccines through the Gavi Alliance. And this 20% is intended to cover all healthcare workers and high priority risk groups in countries that may not have the resources to buy vaccines themselves. In January, just as the Indian program started to roll out vaccines in India, about 63 million doses of vaccines, mostly of the AstraZeneca equivalent vaccine, were shipped out of India for the COVAX facility and for Vaccine Friendship or Vaccine Maitri, which was the government of India donating vaccines to many countries around the world. Now, in India today, we have 3 vaccines that have been approved for use. These are Covishield, which is the AstraZeneca vaccine made by the Serum Institute of India. It's given as 2 doses. It's supposed to be 4 to 12 weeks apart. India's just approved a 12 to 16-week schedule. It's 90% of the vaccine that has been used in India so far. And this is probably the vaccine for which most doses have been used around the world, even though Pfizer is catching up quite rapidly. In the trials that have been done, the phase 3 efficacy trials, it has shown variable efficacy from 50 to 80%. And the trial that was done in the US was just above 75%. There is a safety signal with this vaccine. This is thrombosis with thrombocytopenia syndrome. This is seen in about 1 in 100,000 vaccinated individuals, and many countries have stopped the use of this vaccine, particularly in their younger populations. And in the UK, an alternate vaccine is recommended for those who are below 40 years of age. The next vaccine in India is Covaxin. It's an inactivated vaccine where the virus was from the National Institute of Virology. This vaccine is made by a company, Bharat Biotech. It's given as 2 doses, 4 weeks apart, and is 10% of the vaccines that are used in India. It was trialed in India in 25,800 subjects, and a study of 5,000 individuals is planned for Brazil. Its current interim efficacy is 78%, and there are no safety signals. Sputnik V is the vaccine from the Gamaleya Institute, and that's going to be made shortly in India by multiple manufacturers. A company called Panacea has started that already. It's given as 2 doses, 4 weeks apart, and this has just been released by the Central Drug Laboratory. It was evaluated in trials in Russia and Eastern Europe, shown to have an efficacy of 91%. And there was a trial rather like the trial with the Covishield vaccine of 1,600 participants in India. And according to Sputnik V's manufacturers, even though this is also an adenovirus vectored platform, they are not seeing the signals that have been seen with Covishield and with the Johnson & Johnson vaccine. Now, if we come to the viral vectored vaccines, and I'm only focusing on the ones that are or will be available in India, the AstraZeneca vaccine that I've just described to you got restricted use approval in January and seems to be working very well with the safety issues that I've just outlined. The Gamaleya Institute vaccine is one that has 2 different adenovirus vectors. So the idea of interference with using the same vector again is supposed to be dispensed with, but it seems with the AstraZeneca vaccine, you do see boosting with the 2nd dose. So we'll have to see how this plays out in real life. The Johnson & Johnson vaccine is going to be manufactured in India by a company called Biological E, and its manufacture is going to be supported by a grouping of 4 countries, including the US, where the goal is to make 1 billion doses of this vaccine. This is a vaccine that has been evaluated in clinical trials in the US, in Brazil, and in South Africa, and seems to be working really well. But it's unlikely that this vaccine will be available in India until at least December of 2021. In terms of the inactivated vaccine, the Bharat Biotech vaccine, that's an indigenous strain. It uses a novel adjuvant that came from the US. It requires BSL-3 for manufacturing, and initially Bharat Biotech had said that they could make 200 million doses annually. Now we are being told that they're going to make 700 million or even 1 billion doses annually, because they're going to be making it at multiple other facilities. This vaccine has submitted its paperwork to the FDA in the past week, and is also applying for WHO emergency use listing and hopes to obtain that sometime before September. This is a vaccine for which the phase 3 trial has accrued its 130 case endpoint, but what has been made available publicly is 2 interim analyses, one of which showed 81% efficacy and a second that showed 78% efficacy. We also have what is the furthest advanced DNA vaccine. It started a bit after Inovio, but seems to have moved a bit ahead. This is made by an Indian company based in Gujarat, Zydus Cadila. It's a spike protein on a non-replicating, non-integrating plasmid given by subcutaneous injection. It's in a phase 3 trial with 30,000 participants, and we've been told that they may be submitting data within this week or next week. So everybody's waiting to see what happens with this vaccine. We also have protein subunit vaccines that are in development. The Novavax vaccine is going to be made by the Serum Institute of India. This is nanoparticles which are formulated with the matrix M adjuvant. And while it has had very encouraging results in phase 3 trials, there have been issues with the manufacture of this vaccine, particularly at the Emergent facility. And there are delays in the planned regulatory submission. It was supposed to be submitted to the FDA Q2 of this year, but now it's been shifted to the third quarter. This vaccine will be made in India by Serum Institute, and Serum has already started manufacturing at risk. The advantage of this vaccine is that you can make a humongous number of doses. And that's the same case as with Biological E, which is collaborating with the Baylor College of Medicine. They are making a receptor binding domain based vaccine, which is going to use a CpG adjuvant from Dynavax. This vaccine is now in phase 3 studies, and results are expected in August of 21. We also have an mRNA construct. This is from HTD Technologies in Seattle, which transferred it to an Indian company called Genova in Pune. And they are trying to make an mRNA vaccine that is a self-amplifying RNA that can be stored at the same temperature as other vaccines. They believe they can do this because they have a lipid ion nanoparticle formulation that allows for greater stability. They've done animal studies, including non-human primates, that have been encouraging, and they have just begun their phase 1 trials. India has never had a manufacturing facility for mRNA vaccines, and Genova is building one out and plans to have a manufacturing capacity of 1 billion doses a year. Now, the question that is being asked everywhere is that we have data for these vaccines for a lot of things, but we don't have data for newly emerging variants. And the variant B1617 actually has 3 sublineages which behave very differently. In data that was evaluated at Emory, it appeared that we had bad news because you required 7 times more antibody to be able to neutralize the B1617 variant. Now, the same data similar data were produced from the Gupta laboratory in the UK, which is shown down below, which seemed to indicate that if you looked at this mutant, B1617, then it did not behave very differently from mutants that were like the wild type. A little reduction, but not enough to indicate that you would need to change the vaccine. And that was also shown in studies that were done at the Center for Cellular and Molecular Biology in Hyderabad. Now, the difference between these two, it turned out, was that Emory was using the B1617-1 variant, which is circulating at lower levels around the world, does not appear to be as transmissible as the B1617-2 variant, which seems to have less of a problem with neutralizing antibodies. There's essentially a lot for us to learn about vaccines, to get them out, to use them, and then learn about their performance. We have a population of 1.4 billion, and just with adults, we need 1.9 billion doses of vaccines. Our procurement has become complicated. Our supply is limited. This is our first adult immunization program, and we are dealing with increasing vaccine hesitancy. So we really do have a long way to go. Thank you very much for having both of us here.
Thank you so much, Dr. Kang and Dr. Mukherjee, for incredibly informative presentations. We have lots of questions. Some of the questions were submitted in advance of the panel discussion, and others are coming along. And I want to remind our audience members that please submit your questions, additional questions via the Q&A function, and we will be sure that we address them. So I'd like to start off to ask both of you the question about the second wave in India, starting in major cities, as you've discussed, where testing is more widely available. And thankfully, with lockdowns, the cases now appear to be leveling off or declining in cities, as you've shown. How is the second wave of the pandemic affecting rural India, where most of the country lives? And could the declining case numbers in India be missing rising cases in rural areas where testing may not be as widely available? And either one of you can begin.
So maybe I'll start with that since my microphone is still on.
Yes.
We are missing cases, and we miss more cases in rural areas than we do in urban areas. This is true across the country. It's true in states that have good health infrastructure, and even more cases are missed in places that don't have good rural infrastructure. We are fortunate at CMC to have a network of hospitals that we liaise with in rural India, and all of them are reporting being overwhelmed, and these cases are not getting reported.
Dr. Mukherjee, would you like to comment on how your tracking mechanism is attempting to make up for the relative lack of data from rural areas?
Yes, so I think that, statisticians are not magicians. So if there is no data, then you cannot really create data. But what we see is that only in all our calculation, it shows that about only 6% of India's infections are being reported. So you can see, and the magnitude really varies across different geographical regions and different states. And sometimes we think that the states which are reporting a lot of cases are not doing so well, but it could be the opposite because they're testing more and they're reporting more cases. And some of the apparent metrics and drastic drops that we have seen may not be a reflection of the true reality. So I think that's why I have been really vocal about the need for data, because that really helps us to plan healthcare resources deployment and also designing future policies. So rural India, even rapid antigen tests, there is no, at many places, the nearest testing center is very far, and transportation is an issue too. So many barriers to access of testing. So it's a mystery. But if we look at sort of the trajectory, I still think that we are missing, but the peak probably is going through and has passed. But of course, there is a big unknown.
Yes. And just to stay on the topic of rural India, there's a question that I would direct to Dr. Kang. Clearly, you've shown that India is producing vaccinations and trying to sort of increase the capacity for doing so. And the question then is, what will be a timeline for potentially reaching the 70% of Indians who are living in rural areas? Do you have a sense of a projected timeline where you could even expect to vaccinate adults at numbers that could begin to resemble herd immunity?
So this is something that really scares me, because I've been looking at what's been happening with immunization so far, And even with the 12% and 4% that we're seeing, most of that immunization has taken place in the cities. As I mentioned, we have no adult immunization program. We are trying to build this from scratch. And what is being done is the places where there is missing infrastructure, there is really not an ability to deliver vaccines. And that's the rural areas, and that's the tribal and more remote areas of the country. And at the pace that we are going, I can't even begin to make a projection about when we will do this. It's beginning to look like somewhere between 3 and 5 years. And that's just unacceptable.
Yeah. That's sobering. I wonder if we can pick up on something that both of you have alluded to, which is vaccine hesitancy. We here in the United States, we're dealing with vaccine hesitancy, and yet our numbers of vaccination right now has really gone up. To what extent do you think that vaccine hesitancy may impede the ability to actually reach people even when they have access to vaccine? And is there any difference between the rates of hesitancy in rural areas versus urban settings?
I think the patterns of hesitancy are different and the drivers are different. So if hesitancy is a lack of uptake, in rural areas and in urban slums, this is considered a disease of and a vaccine for the richer population. So if we go into those areas, they say this vaccine is not for us. Sometimes they don't even know that there is a vaccine for this. So there is a lack of information that is contributing to that hesitancy. People don't know that there can be adult vaccination. They have only known about childhood vaccination before. And then, of course, we have all the forms of hesitancy that are exported by the Western world. So whether it is about, everything is circulated as videos on WhatsApp. I spend a lot of my time countering those for people running programs, but you have to create tailored messages. We are a very diverse country with many languages and much stratification, and the messaging has to be very carefully done.
Yes.
So I just want to mention that, there is an incredible potential of engaging religious and community leaders in the rural areas. And that is a technique that we have seen being successful all around the world to penetrate certain communities. So there is certainly a network effect or a peer effect in vaccination. So I think that everybody has a responsibility to convert and actually talk to their social circle, but also in rural areas, community health workers, ASHA workers, religious and community leaders. I think that the tactics has to be very, very different. Whereas in urban areas, I hear from many of my friends about blood clots and other of the scientific literature. So it has to be really tailored depending on which community you're talking about.
Absolutely. Great point. And in fact, we're finding that in this country that using civic groups, churches, and others have allowed us to actually penetrate into communities that otherwise would have had lower rates of vaccination. So great point. Dr. Mukherjee, while you still have the mic, I'd like to ask this next question. You've been vocal regarding the importance of public health measures, and you've talked passionate about how it works and how it could have averted so many deaths and infections. And we've just talked about these challenges of rolling out vaccinations to the adult population. So what is your thought about what public health measures can and should be implemented at this stage of the second wave? Are you, for instance, recommending complete lockdowns?
So it really depends on which state we are in, right? So there was not a national lockdown. We saw a cascade of lockdowns depending on what each state was. And the policies really differed across the states. And actually, Ram has done also a lot of work on what we have learned about the transmission of this virus in the last 14 months, and how can we use that to do strategic reopening? What are the really high risk activities that we have seen in several scientific papers? For example, indoor dining, restaurant, bars, coffee shops, gyms. These are always at the highest list of every paper that I have seen. So as in many states, I think it will come to a point that, and no state can actually hide behind the shields of lockdown in perpetuity. So you'll open up, but you have to be really strategic and intentional and use science. For example, in India, some of the restricted hours for the markets, if it's 3 hours, then everybody tries to go to the market at the same time. Instead, maybe mask mandate and also low capacity. So it just very nuanced, and also this simple public health message has to penetrate the society that we have to wear our masks until a large percentage of the population is vaccinated. That's sort of our personal immunity and prevention, and we all have to design those strategies in a very careful way.
I like that, personal immunity. I like that. Even while we wait, why everyone waits to be vaccinated. Dr. Kang, you have been appointed by the Indian Supreme Court to a task force that is being charged with ensuring equitable distribution of oxygen to states. Could you tell us some of the ways in which this is being implemented?
So there were incredible oxygen shortages in Delhi about a month ago. And part of the reason for that was that oxygen is produced in Eastern India and used everywhere else. So it's produced, liquid medical oxygen is a byproduct of the steel industry in India. So if you don't have local production, you need to arrange transport. And what was happening was that oxygen was being produced in some states. And if they had excess oxygen and wanted to send it elsewhere, they had to use tankers, and the tankers belonged to other states. So states that needed the oxygen were essentially stopping the tankers from crossing their state borders. So the central government had to step in, and it has been extremely challenging. There is an approximately 10% gap between the maximum capacity to produce and the required usage. A lot of this could have been appropriately addressed if we'd gotten oxygen audits in place first. So guidance for those audits, guidance for transport mechanisms, guidance for production mechanisms, and storage is what the task force is working on now. We've given our draft recommendations to the government last week, and we will have another update this weekend.
Dr. Kang, I wonder if we could stay on that for a minute. Many people in the Tufts community have reached out to our leaders to ask what we can do in practical ways to support the efforts, knowing that, of course, the solution has to come from India. But on the topic of oxygen, is there any way that we as friends of India, outside of India, could help?
It's challenging. I think the best advice that I can give is to find NGOs, civil society organizations that are working on the ground in India and try and support them directly. There are many of them that are doing an absolutely incredible job. And right now, if you buy equipment or materials, whether that's PPE or masks, oxygen concentrators, pulse oximeters, and send those over, then those can be delivered to the CSOs that are working on the ground. And there are verified sources for which ones are really doing their job.
Thank you. Dr. Mukherjee, the work that you're doing with tracking the pandemic in India is incredible. And I wonder whether your team is considering similarly tracking pandemic in other low-income countries. And I'm saying this because there's been a concern shared that what happened in India may be a herald of what could easily happen in other countries where resources are even more limited and where people have made the assumption that perhaps they've escaped the bullet. Many countries in Sub-Saharan Africa, for instance, have relatively low rates of prevalence of COVID infection and even deaths. So to what extent do you think we can help the global village to anticipate and potentially avert what is happening in India in other resource-limited countries using your data and analysis?
That is a great question. So this is a very scalable model, and all our codes, how we set up the Shiny app, everything is public. So this is where I think other people can help. We have finite resources, but we are very happy to share everything if anybody is interested in replicating this for other states, because you do have to understand the context. Every country is so different. But as a statistician, what I would recommend is that really tracking the data at a granular level, because you can pick up the signs of the uptick, even at every district having a surveillance officer, an epidemiologist. We have not invested in public health as a discipline. So I think that it is time that the world recognizes that and really manages that at a much more granular level and become very data agile. And I also want to say that India's example is a lesson for many of us, right? That first of all, seroprevalence surveys. Many big cities in India said 50%, 60% people have antibodies, but then those were the places which got really affected by the second wave. So there is no complacency. We always have to err on the side of caution and have to embrace our public health values at an internal level, at an individual level, because it so much depends on human behavior.
Yes, and I can appreciate how difficult it is to actually influence human behavior for sure.
Yes.
Dr. Kang, and this question is being posted in the chat for you. It appeared that, first of all, you've been involved in doing serologic testing across the country, and to what extent can we make use of that data set? Again, in planning towards how the pandemic is going to roll out, or even how to even roll out the vaccine, national vaccine plan, which you've already correctly pointed out does not exist. What is the validity of having data, serologic tests that allows you to know who's already been exposed and infected by the COVID vaccine, by the COVID virus, sorry?
So I think we need serological data actually now. We've just had the second wave. This is the time to be doing it, to understand what this means for vaccination programs. Can we go with a single dose vaccine for the bulk of the population or the population in urban areas, and think about 2 doses of vaccine for higher risk groups or rural populations? I think absolutely, we need to be doing this now. We haven't vaccinated enough of the population to, be in a situation where we can't distinguish the infected from the vaccinated. And I think the other thing that we need to be doing is looking at clinical information. What is the percentage of symptomatic reinfections? That's really critical. Reinfections with which variants result in symptoms, result in severe disease, result in death. Because if infection has no protection whatsoever, against severe disease and death, then this is a very strange situation for a virus. It shouldn't be like that, but we don't have the data to show us any different.
So a terrific point that it's really important to have that serologic survey ongoing, even in the midst of this second wave. And on that topic about a virus that behaves in a strange manner, there's been reports of long-term effects of COVID-19 infection, potentially even among people who may have been asymptomatic. And there was a recent BBC report, for instance, that spoke to this. And I wonder to what extent are there plans to also surveil people who've been infected with the virus long-term?
So one of the first things that it did last March was to ask my colleagues to establish a cohort of people who had been infected, and we have 5,000 people in that cohort now. These are people who had infections early on in the pandemic. And we are seeing about 4% of people with persistence of symptoms for up to 6 months. And that seems like it's a bit less than has been seen in other parts of the world, but this is a very intensively followed up cohort. So I'm pretty confident that that's what the data are for that cohort. Will it change when you have infections with a different variant? I really don't know. This is a virus that has multiple modes of pathogenesis, everything from coagulopathies to autoimmunity. So we really do have a lot to learn about it.
Yep.
So I would like to add a little bit, because I have been really doing a lot of research on long haulers in University of Michigan electronic health record system. And I think it's really important to establish a national cohort, but also think about policies which will support them. And it's not just, the COVID symptoms and sequelae that we are talking about. As a society, families have been destroyed and ravaged. So what are we thinking in terms of policies for mental health support as we heal as a country? And even in the long haulers, you see psychological and neurological disorders turning out to be something which is strongly associated post-COVID. So what are we doing? What are we thinking about that? I also wanted to ask Dr. Kang something about vaccination for 0 to 18 age group, because 40% of India is in that age group, and we have not really talked about that. So the hope of reaching herd immunity with 40%, where we have not even started, what are thoughts on that?
Yeah.
I think ultimately we are going to need to immunize children, but the time for that is when you've immunized higher risk groups. So even in discussions at WHO, there is a fair amount of discussion that is ongoing about what is the right time to begin immunizing children. And the general consensus is we need to think as a globe and not as a country.
Thank you.
Dr. Mukherjee, actually, this question is for you, and I think it follows nicely the response that Dr. Kang just gave. You are leveraging the incredible resources of the University of Michigan and your expertise and intellectual powerhouse to really do this tracking and provide data and modeling. To what extent do you think, as somebody who is part of the India diaspora but living outside of the country, to what extent have you received receptiveness, particularly among policymakers, to the kind of expert advice that you can offer? And I just am curious to know to what extent potentially you might be collaborating directly with the government in helping to deal with this crisis.
Yes, so I think that in the beginning, we started this last March. And so our report was sort of like a bombshell on March 16th. It was on our website. And I wrote a Medium article because the urgency and the immediacy of the situation, we quickly realized, and our whole team, that it cannot take the standard academic route, right? By the time you get peer reviewed and published, the wave is gone. So you have to really release information in real time. That was a true challenge for an academic because we are not used to these modalities of going on a television show and talking about our projections. And we always try to quantify uncertainty, which people don't understand. And policymakers always take the lower credible interval and media always takes the upper credible interval. So these are all challenges that you actually face. But in terms of communicating with officials, there has been many conversations with state officials primarily, but also with Niti Aayog sharing our projections. But most of them have happened when I was screaming in February. I don't think anybody, including my own parents, paid any attention that there is an uptick coming. But gradually, when the things became worse, then people started contacting about projections. But I think the early intervention piece, and when you see the uptick, if you really intensify, then you can actually avoid such drastic measures. That message, I feel defeated because you make these projections so that they don't happen, right? So somebody takes you seriously and says, yes, this can happen, and let us intervene so that we can beat those dire projections. So there has been a sense of, a lot of public engagement, a lot of raising awareness, but at the end of the day, I also question that how much did it help?
Yeah. Even as we are hoping that India makes it out of this second wave, there are predictions that this is probably not going to be the last worldwide pandemic that we experience in our lifetime. So I wonder if the two of you could speak to what steps we can begin to take right now, what kinds of, and I hate to even imagine us not thinking about COVID right now and to entertain the possibility of other viruses, but what steps, what lessons learned from this really tragedy, nationwide tragedy in India and around the world, can we learn so that we can keep our eye on the next pandemic that may be coming our way?
I think global surveillance and networking for pandemic preparedness is going to be essential. We may not be lucky next time. I think we've actually been lucky this time because this was a pandemic we could vaccinate our way out of.
Yes.
What if it was a more challenging virus where we couldn't get a vaccine made so quickly? What would we have done then? We have a virus now that has a low infection fatality rate. If it was something that was as transmissible as this one is, but had the same fatality rate as SARS-CoV-1, we would not be in this situation. So I think just being prepared for how bad things can possibly get is something we need to think about. I know it requires investment, and the idea of insuring ourselves in the hope that the worst will not happen is not something that politicians want to address, but we have to figure out a way to do this.
So I'll just make 2 points. I agree completely with what Dr. Kang said. I think this moment has really taught us that our health is interconnected. The UK variant is causing a surge was causing a surge in Michigan. The Indian double mutant is in UK. So there is no escape. No one is safe until everyone is safe. So that's the first thing, that you cannot just focus on your constituency, your own country, your own state, because the virus does not really listen to those borders and immigration rules. The second thing is rare probability events can happen, and staying prepared for them to convince public that we are investing so many dollars and into public health policies and surveillance may be difficult when things are not happening over a 10-year period, but it's still wise, because once in a lifetime when it happens, the crushing social and economic consequences it has far outweighs the consistent management of preparedness and awareness. And so that is something we forget, particularly in a tight resource setting. Even look at India, that all the plans that were rolled out in wave 1, some of them were stopped because we felt that the virus is not going to come back with the second wave. Oxygen production, scaling up of COVID care facilities, many things were sanctioned, but people felt, oh, we actually dodged the bullet. So this is our life lesson, that preparedness, even if it does not happen, it is really prevention is the key, investment is the key there. Otherwise, you spend a lot of money and trillions of dollars of economic stimuli down the road.
Absolutely, not to mention the human toll that you referred to earlier, including mental health and even just from the massive loss of lives that people have suffered in their families. So this question actually brings us to the way you personalize the data points by sharing with us about your own father suffering from fighting COVID-19 now. And the comment says, this has been the worst time in our life. We lost members in our extended family due to lack of oxygen. Now getting the slot for vaccination is a Herculean task due to the shortage of vaccines. It almost feels like each one is on their own. So I wonder if the two of you could speak to how the pandemic has sort of affected you personally as we sort of begin to wrap this conversation up, just sort of bringing it back to the personal toll.
So for me, in our family, we've been really lucky. My children are in healthcare, so got vaccinated, and my husband and I are vaccinated as well. And our extended family consists mostly of elderly individuals who were able to isolate. And we are one of the few families that we know that has not yet had any cases. But we have a lot of friends who've been infected. In my research group, at least 5 people have lost family members. At least about 20% of the group has been infected. So it's been quite a difficult time because we've tried to be there to support people when their families were in hospital or in the ICU, and not been good. Overall, professionally as well, this has been a challenging time, and sometimes difficult in India to speak up, and because you tend to get pilloried for it. But I've been fortunate to have a platform at CMC from which I can speak. So I've been trying to do that.
Thank you. Dr. Mukherjee.
Yes, so I of course, we started modeling this in March of 2020, and all of us thought that it's a very naive idealism that by doing this work, by doing this public health messaging, we could actually make some impact and protect our families, because we are really concerned about our parents and our loved ones back in India. And so I felt on April 26th, when my father called me saying that he was running a fever, I really felt that my fight is over, I told him that, how can you do this? I have been working on this. I cannot at the personal level, I cannot lose you to COVID. And, he's an actor and he has always been surrounded on stage by audience. For him to walk into a hospital in complete solitude and isolation with only his phone and no family around was traumatic. I stayed up all night here to give him boost and moral support. And, you know, at the end of the day, I will give him all of this, like you have to do pruning and all of the research that I have learned, what medication I try to communicate with his doctor and nurses because of the time difference. Essentially, I went to bed at 3 a.m. and got up again at 6 a.m. to do my day job. And it's not just me. I know many of my friends are in the same situation. Every phone call is unnerving because you think that somebody is gone. And so at night, my father, completely delirious, will still say, we are co-fighting this, right? Aye, Captain. And so that's what I want to share. Aye, Captain. And that's what he will say. We all fight this battle, and he's back home. And I really appreciate all the thoughts and wishes. But as a population health scientist, when you see this personal, population, community level trauma, and I look at my mother, who is wearing 2 masks and a face shield, 80 years old, like a soldier walking around the house, then I know that, you know, you can fight. And so I embrace that spirit of humanity. I embrace the spirit of the youth of India running around the streets with oxygen cylinders on their back and trying to help people through getting COVID a vaccine appointment on the app, doing their best, the Red Volunteers, all of the humanity that came forward. So in spite of in terms of a policy paralysis, in spite of the poverty, in spite of lack of resources, I still somewhere find a strength and comfort in humanity.
That is incredible, to have the hope that you just expressed in spite of it all. I feel like we can all hold on to that hope. I want to thank each of you so deeply for spending this time with us, for educating us about what is happening in India, not only from the intellectual standpoint, from the immense expertise that you have, but also really educating us about what it feels like to have the personal impact of this pandemic. And we stand in solidarity with you and with all our friends in India. Thank you for joining us. I'd like to spend the last few minutes to really thank so many people that made this seminar possible. And I want to first thank our planning committee. You've already met some of them, Dr. Noreen Ward, and you've also met Dr. Ram Subramanian. I want to also thank Kim Burke, who was behind the scenes in working to set this up and help us. Kim is the program administrator in the medical school. I want to thank Andy Colbert, who has been behind the scenes helping us with that audiovisual and AT support. And I want to extend deep thanks to the Office of the Provost, and especially Provost Aubrey, for your incredible support and sponsorship, close sponsorship of this. Huge thanks to the President's Office for your support of this seminar. And of course, big thanks to Dean Bates and the medical school for co-sponsoring, along with Tufts Medical Center, Tisch College, and the Office for Research of the Vice Provost for Research. Thank you all for joining us. This really is a global village, and this is a global fight that we are all in together. And so thank you for coming, and want to extend best wishes for those of you who are personally dealing with this, and hope that we get out of this together. Thank you again.